Hello everybody and welcome to the Carolam Cymru revision sessions. This session this evening will focus on AS psychology and will be presented by Miss Bellis from Allen School, Flintshire. The session will last around 40 to 45 minutes and Miss Bellis will run through the relevant content. The Q&A section is available if you have any questions. And the recording will be shared on the e-sgol website following the session for you to access via our e-sgol website under the Carolam Cymru tab. Thank you so much, Miss Bellis. Over to you.
Thank you. Hi everyone, welcome to the second AS psychology session. We are currently focusing on all of the different therapies you need to learn within Unit 1 of the psychology exam. And today we're going to focus on the cognitive therapy and the therapy within the behaviourist approach as well. So we're going to be looking at CBT, cognitive behavioural therapy, and systematic desensitisation. So for each of the 5 approaches, you will need to study one type of therapy. And a therapy is a form of treatment. It's the treatment that the approach believes is the most effective way of treating slightly abnormal behaviour or a mental illness that the approach focuses on. Now, there are lots of different therapies that you could be taught in school, as the psychology specification gives us a big list of possible therapies and we get to choose. So the therapies that I'm working through with you today may not be specific to the course content that you're being taught, but at the very end I am going to talk about exam practice, so that will be relevant to you in helping you achieve the most marks in the exam. Just some top tips are also on the screen now, and I will refer to these as I go through the presentation. So our therapy questions are a really important section of the exam because they are normally your higher marked questions. It's normally the 8 and 12 mark questions, which is the highest possible mark, really. I have been an examiner for WJEC for quite some time now, and I've never seen above a 12 mark question. I'm not ruling it out because you never know, but 12 marks is our highest mark question, and if we can get it right and get that 12 marks, sometimes it can be the difference between one grade and another, so it's really, really important. You can be asked to describe and evaluate the therapy. I'm going to focus in this session at the describe element of these questions, but please be mindful that you also need to look at the evaluation of them. Adding examples is very important in gaining marks. In order to reach that top mark band, that 10, 12 marks, having examples, having pieces of evidence and pieces of psychological theory to back up what you're saying is really, really important. And I can't stress that enough, that you can have the most perfect description of something, but if you haven't given examples, then you will not reach that top mark band. And then the next thing that's really important is appropriate terminology. Psychology as a whole is very terminology heavy, and there are lots of words that you won't have used or seen before. But embedding them in an answer is what is also going to get you right up the top of that mark scheme. So terminology and examples are definitely our main focus when we are writing essays, especially on therapies. Okay, starting off then with cognitive behavioural therapy. So we are in the cognitive approach. Now, we all know that the cognitive approach is to do with internal mental processes and how we receive, process, and then output information from our environment. And what CBT aims to do is to change a possible faulty thought process that somebody may have had or learnt or required over time. So one of the most important applications of this approach is that they want to understand and treat mental health problems. And most commonly, cognitive therapies are now most commonly used in clinical psychology. So what they normally do is, for example, say they have somebody that has got depression. They will, firstly, they would use the biological approach and they would administer an antidepressant drug. So normally an SSRI or something that increases the amount of serotonin in the brain. And then once they've got on top of the actual symptoms, cognitive behavioural therapy will be used to help the patient really understand why they feel that way. Has there been a significant trigger? Is there a way that they can change their thought process to help them day to day understand their condition and therefore implement the right strategies to overcome it? So most of the time, CBT and drug therapy work quite closely together. The aim of all the therapies is obviously to make the patients feel and function better. And CBT aims to achieve this by altering the ways in which people think, which can then alter how they behave. So how they think is really important, and how that then alters their behaviour. They are two really important elements of CBT. So one of the first things that they do is they consider your internal mental processes. So an internal mental process is part of an assumption for this approach as well. CBT combines cognitive therapy, which is you examining how you think, and behavioural therapy, which is examining the things you do. And it's based on the idea of internal mental processes and how we think and perceive ourselves and others affects our emotional state and our behaviour. So what we think others think about us influences our behaviour. And like I said previously, it's most commonly used to treat anxiety and depression, but it can also be useful for other mental and physical health problems. In year 13, one of the behaviours that can be looked at is schizophrenia, and CBT is also evidence to help people with forms of mania like schizophrenia. So it can treat a wide range of different conditions. CBT cannot remove your problem, because most of the time you have developed the mental illness because of a trigger. Something's happened that has caused it. Now, CBT can't make that thing that's caused it go away, but they can help a person deal with it in a slightly more positive way. They can alter your thought process. So, negative thinking patterns. Normally, if somebody is diagnosed with depression, for example, it will lead to or be caused by continuous negative thinking patterns. So it's based on the concept that your thoughts, your feelings, and your physical sensations and actions are all interconnected, and that negative thoughts and feelings can trap you in a vicious cycle. Now, there's a really famous researcher called Aaron Beck, and Aaron Beck created this cognitive triad where there's 3 elements to a person, and if they get trapped within the 3 elements, it can lead to depression. 3 elements are negative thoughts about yourself, negative thoughts about the world, and negative thoughts about the future. You have these and you continuously get yourself in that cycle. Sometimes it's really, really difficult to crack the cycle. And that's what CBT aims to do. It aims to crack that cycle, and it breaks down overwhelming problems into smaller parts, showing you how to change these negative patterns to improve the way that you feel. So the whole idea of CBT is to challenge those negative thinking patterns. So they can start from childhood. We know as psychologists that childhood plays a massive part in the development of a person when they're older. So for example, if you didn't receive much attention or praise from your parents or teachers at school, you may have thought that you're useless, that you're not good enough. This is, again, a negative thinking pattern. And over time, you might come to believe and internalize the assumptions until as an adult, these negative thoughts become automatic. So the way you think may then affect how you feel at work. So if you've never been praised and you think you're not good enough, you may internalize that and think you're not good enough in work, you're not good enough in school, you're not good enough at any extracurricular or clubs or hobbies, and it can really consume your life. If it consumes your life for long enough, it can lead to depression. Okay, another element of CBT that's really important to focus on is how we respond to the world around us, which is schemas. Now, a schema is a fixed packet of information, which means it's almost very, very similar to a stereotype. So we have a schema that something that has got a tail, 4 legs, and it barks, that is a schema of a dog. Everybody will be able to recognise that schema. And it's the schemas that influence how we respond to the world around us. So Beck suggests that depressed people develop negative schemas of 3 things known as the cognitive triad. So this is what I was talking about before. They have this negative idea about these 3 things: themselves, everything around them, and their future. And CBT helps change the negative schemas. So this is just a little sort of model diagram to illustrate Aaron Beck's cognitive triad. So at the top it says, I feel low / depressed, and your thoughts could be, I've let everyone down, they're all angry with me, I'm not a very good friend. And then you may think, oh, do you know what, because I'm not a good friend and they're angry, I'm not going to go out, I'm not going to see people, I'm going to withdraw. That's going to make you feel low. Then you're going to overthink it and again go into this vicious circle. Same with the feeling of anxiety. I feel anxious, I can't do this, what is wrong with me? Everyone is looking at me. And then behaviour, you want to get away from the situation and avoid it. That's going to make you feel more anxious, and again, so on and so forth, again in a vicious circle. Now, on the screen it says revolving door syndrome and a question mark. Now, revolving door syndrome is something that we spoke about within the biological approach. It's the idea that drugs just alleviate the symptoms and the pain, but they don't ever fix the root cause of a problem, and you end up just going in and out of a revolving door and nothing really happens. And that's the same really as what happens with CBT. Nothing happens, it's just continuously going around, and cognitive behavioural therapy breaks that up. It breaks that negative thinking cycle. Okay, so if your negative interpretation of a situation goes unchallenged, then these patterns in your thoughts are a continuous cycle. So in CBT, you work with a therapist and you identify and challenge any negative thinking patterns and behaviours. In turn, this can change the way you feel about situations and enable you to change your behaviour in the future. You and your therapist might focus on what's going on in your life right now, but you might also look at your past and think about how your past experiences impact the way you see the world. So, for example, if I go back here, if you are feeling anxious and your thought process, so here, is everybody is looking at me. Well, if you're in a CBT session, the therapist would say, well, where's your evidence of that? What evidence have you got that everyone was looking at you? Or what evidence have you got that everyone is angry at you? And when you can't provide evidence, it breaks that cycle, because then you know, oh, well, that is just a thought then, that is just me, that is just faulty thought process. And actually, it's not real. And that's the first thing they do to sort of crack that cycle. So the 3 main components, the 3 main bits, 3 main principles of this therapy. You've got the dysfunctional thought diary, cognitive restructuring, and something called pleasant activity scheduling. Now, these 3 things are really, really important to bring into an essay because they are the main bits. Okay, this is what an examiner is looking for in your answer. It's also what will be on that mark scheme. We'll start with dysfunctional thought diary. So within a CBT session, they will set you homeworks. And the homework will be keep a record of what's going on in your life, how you feel, any emotions, any meetings with people, just almost literally like a diary. And then what they do with the therapist is they write down and record their automatic thoughts, and they rate if they believe that they are going to come true. So using a scale there on the screen between 1% and 100%, how much do you believe in that thought? Once they've done that, the clients are asked to write a rational response to the automatic thoughts. So a rational response is thinking about, right, if somebody else was to say that to you, what advice would you give them? Because a lot of the time we can give other people advice, but we really struggle to take our own advice. And then finally, the client re-rates their beliefs in their initial automatic thoughts. So they write down their thoughts, they rate how much they believe they'll come true. They write a rational response as if they're going to help someone else. And then once they've got their rational response, they then re-rate that belief again. So that's the first element, dysfunctional thought diary. The next thing is cognitive restructuring. So this is a little bit about what I was talking about before about evidence. So once the client has revealed more about their thought patterns through the use of the diary or discussion, the client and the therapist can work together to identify and change negative thought patterns. And this is known as therapy during therapy. So, for example, a client may be distressed that they think they overheard someone talking about them. During CBT, during CBT, the client is taught to challenge these automatic thoughts and ask for evidence. So where is evidence that those people were talking about you? What's the worst that can happen if they were talking about you? By replacing the dysfunctional thoughts with more logic and constructive ones, the client can try out some new ways of behaving. Once they've got their cognitive restructuring in place, they can then implement some pleasant activity scheduling. So this is something that we all do, actually. All psychology have done here is put a fancy term on something that we kind of naturally do every day. So this technique involves asking the client to plan for each day, perhaps over a week period, one pleasant activity per day. It should be something that gives them a sense of achievement. So going to a new gym class or something that involves a break from the normal routine, eating lunch outside instead of in their office. This means that they will look forward to something, and that will bring on positive emotion, and it also distracts them from a negative thinking pattern. For example, if you are not having the best day and you're feeling a bit down, sometimes people say, oh, do you know what, I'm going to go out for tea tonight. And that is us pleasant activity scheduling, just without really thinking about it. It's just having something to look forward to. Okay, so those three elements, dysfunctional thought diary, cognitive restructuring, and pleasant activity scheduling, absolutely need to go in an exam question here. I'm going to take you back to the top tips. You need to describe what is CBT, and that's where you would bring in Aaron Beck and the idea of the schemas, and you would link it to internal mental processes. Having some examples, so I've implemented quite a few examples, especially when it's to do with asking for evidence. That will really help you boost your marks. And then terminology. So things like pleasant activity scheduling, cognitive restructure, therapy during therapy, dysfunctional thoughts, they are all key terms that will really, really help you gain marks here. Okay, so that is our whistle-stop tour of CBT. Next up, we have got systematic desensitization, which is part of the behaviourist approach. Now, the behaviourist approach focuses on phobias and how we learn phobias, and then how we could possibly unlearn a phobia as well. And that's what systematic desensitization is. It's us unlearning a phobia. So a little recap of the assumptions of this approach, because they come into this quite a lot. First up, you have got blank slate. It translates in Latin to tabula rasa, and that means that we are completely blank. We are born blank, and everything about us and everything we've ever learned and anything we know is due to our environment. The only things that we can do are cry, feel hungry, breathe, obviously, and feel pain. Those 4 things are innate. They are biological. They are the nature side of us. Everything else, according to the behaviourist approach, is your environment. It is learned from what's around you. Okay, so that's here. That's your first assumption. Second assumption, and the main sort of assumption, especially for systematic desensitization, is conditioning. Now, we can condition ourselves and others to do certain things. Conditioning just means learning, and there's 2 different types. There's classical conditioning and there's operant conditioning. You've got 2 researchers for that. You've got Pavlov's dogs and you've got the Skinner box. Now, 2 different types of conditioning. Operant conditioning, which is Skinner, and that you learn through consequences and reinforcement and punishment. And then you have got classical conditioning, which is all to do with learning through association. So it's that element that we'll come back to throughout this little presentation. And then lastly, the last assumption is all to do with humans and animals learning the same. Lots and lots of behaviourist theories are completed on animals, and then their results are applied to humans. So, learning and unlearning. The behaviourist approach believes that everything we do is learned, and therefore they say that if we can teach somebody something, we can actually make them unlearn it too. So the main assumption of classical conditioning, I've abbreviated it there just to CC, is that behaviours are learned. So the behaviourist therapies draw on OC and CC, classical operant conditioning and classical conditioning, to help people unlearn learned behaviour. Behaviourists assume that mental disorders are a result of faulty learning and associations. So if you are phobic of spiders, for example, the behaviourist approach would say that you've a faulty learning and a faulty association between spiders and fear. So systematic desensitization is based off of classical conditioning mainly, that we learn through association. You associate your feared object with the feeling of fear and being scared. It was created by Joseph Wolpe in the 1950s, and it's primarily used to treat phobias. It assumes a person has learned a negative association between 2 objects, and now they associate the phobic object with fear. Again, with this one, like CBT, there are 3 main elements that you need to know: counter conditioning, reciprocal inhibition, and this idea of reinforcement once you have a relaxing environment. So, first of all, well, these are your 5 steps. I'm going to talk you through each step, and then I'm going to talk you through some of the main elements. So, number 1, the patient is taught to relax completely. They're given loads of different relaxation techniques so that they can just chillax and not worry about feeling scared. The second one is to do with the desensitization hierarchy. Now, what this means is that the client and the therapist sit down and they say, right, what's the worst possible thing that can happen with your phobic object? So say, for example, we say it is a spider, and the worst possible thing that could happen is it's on me, it's crawling on my clothes. And the least bad thing that could happen is that I look at a video of a spider. Okay, you have to rank them, and there's normally between sort of 10 and 8 different elements that you would rank. What they do is they go from the least fearful stimulus, so the video of a spider, for example, and they would do that, and they would make sure that they are relaxed the whole time. Once they've done that, the patient then moves on to the next step, and then eventually they will go work through all the different sections of the hierarchy and master that feared situation. So what happens is it allows the person to re-experience the phobic stimulus, but really gradually. And now gradually and gradually and relaxation actually are two really important bits here, because they really help it ethically. So they are gradually exposed to their phobic object, and they are taught to relax at each stage. The therapy begins by teaching them relaxation techniques, and the client learns about reciprocal inhibition. Now, reciprocal inhibition means that you cannot have or feel two contrasting emotions at the same time. You cannot feel relaxed and scared at the same time. So if we make you really, 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 really relaxed, then physically and physiologically, you won't be able to feel fear. And that's how this works. It's called counter conditioning because the client learns a new association that counters the original phobic association. So it's a new association with your phobic object and relaxation rather than your phobic object and fear. The desensitization hierarchy, and I know I've just explained this to you, but I'll explain it again. So the client is asked to rank their fears about a phobic object or situation in a hierarchy, and then the therapist works through the hierarchy, gradually exposing the person to the stimulus. Now, what's quite nice is that you won't be told when you're ready to move on to the next step. So say your first step is watch a video of a spider, and then the next thing is go to a zoo and look at a spider through a window. You, as the client, have complete control over when that happens. When you feel ready to move on to the next one, you can. And it really, really empowers the individual and actually puts the onus on them, really, doesn't it? So that they have the choice and the control of their own thoughts. Okay, so one really good thing is to think about different types of phobias that people have and see if you could come up with a desensitization hierarchy. So I put two examples on the board, kittens and mannequins. Now I've put mannequins on the board here because my sister is really, really phobic of mannequins, and I've tried to use this on her quite a few times, and I haven't really gotten very far because she doesn't really give consent for me to show her a mannequin, so she withdraws from the research every time. But have a think about the stages that you would take to help somebody, either yourself or somebody you know, to overcome a phobia. Because if you apply this to yourself or people that you know, it really, really helps you understand just how gradual it needs to be. Okay, another element of this is about having different forms of systematic desensitization. So there's two different forms that you need to know about: in vivo and in vitro. So in the past, clients are gradually desensitized by exposing them to the real feared object, and that is known as in vivo desensitization. In vivo essentially means that you physically have that object in front of you. You don't think about it, you don't use it virtually, so via virtual reality or via a simulator. It's actually having that object in front of you and gradually either getting closer to it or seeing it in different forms, but it's the physical object right there. So that's in vivo desensitization. But nowadays, clients sometimes are asked to imagine the phobic stimulus. So this is more covert desensitization, whereas in vivo would be overt desensitization. Now, if you're asked to imagine the phobic stimulus, this is called in vitro. So the client is asked to think about your object, think about the possible worst experience with it. In vitro, that's called. Now, every year, my students really struggle to remember the difference between in vivo and in vitro. But you think in vitro has got a T in it, and the T stands for think, and that's you thinking about that object. That's how we remember it in my school. Vivo, physically having it in front of you. Vitro, because it's got a T, it equals think about it. Now, I don't think it would be any surprise to you that researchers found that in vivo therapy is much more successful. Remember, vivo therapy is physically having the object in front of you. Because thinking about it, although yes, it has worked for some people, the only way really to overcome a phobia is actually face it firsthand, isn't it? Okay, lastly on this slide, it also says about modelling and the social learning theory, SLT. Modelling is used when a client observes another person overcoming their fear. Now, a social learning theory essentially means that you are influenced by role models and people that you look up to. So if there was a spider on the floor and your parent or carer jumped up on the chair or jumped up on the sofa and screamed and made a really big deal out of it when you were little, you are going to learn that behaviour because you have learnt it from your environment. So sometimes parents have to try and be very, very calm and create a newer association between two things so that you don't pick up on their fear. So there you go. Those are your, well, two main different forms of systematic desensitization. Okay, so I've spoken to you quite a bit about terminology, and that terminology is really, really important. Systematic desensitization, I think, has probably the most amount of new terms that you probably won't have heard before or heard in a different subject as well. They are quite psychology specific, these. But there's something that you definitely need to familiarise yourself with. So reciprocal inhibition, the idea that you cannot have two contrasting emotions at the same time. So you can't feel scared and you can't feel relaxed together. Counter conditioning is the idea that if we can learn something from our environment, we can unlearn it and make a new association. Neutral stimulus is something that is yet to be associated with, and I'm sure you will have learned more about that with Pavlov's dogs. Operant conditioning is the idea of reinforcement, and that we are reinforced positively because we now associate the phobic object with being calm rather than being scared. Systematic desensitization, which is the idea that you are gradually introduced into your phobic object being relaxed at every stage. Desensitization hierarchy, again, is the idea that you rank your best to worst situation with your phobic object, and you work through that ranking with a therapist, being relaxed and calm at every stage. And then lastly, gradual exposure. Gradual exposure means it's very, very slow, it's very anxiety controlled, and it's all in the hands of the patient receiving the therapy. So those are definitely words I would include in a describe question. It might be worth writing them down and making sure that you tick them off as you go. Okay, some more top tips then. Well, the top part of this is similar to the very start of this presentation. Again, higher mark questions, we need to make sure we get this right. Being able to describe and evaluate the therapy is really important. Having examples is very important in gaining marks. So throughout this, I've spoken about spiders. You could bring in other different phobias, especially when you're talking about the desensitization hierarchy. Terminology will help you improve your mark, and as you can see now, there's lots and lots of terminology that you can include. And then also at the bottom, I've got some revision tips. So a keyword glossary, write down all of the key terms and then write their definition next to them. Keep going over them, cover them, then write the definition, make flashcards with the word one side and the definition the other, so you can test yourself. And then create a mind map of information you do know, and then go back, check your notes and add in any missing information in another colour. It's really important that you know what you do know, but that you also know what you don't know, because then you can evenly split your revision time between going over what you do know, but also making sure that you know and you're revising the elements that you aren't sure on. So those are my top revision tips where I would start for sure with looking at these therapy questions. Okay, so I hope that session was useful to you. I hope that you have been able to take some points away from that. The next session, I'm going to look at mindfulness, which is the therapy of the positive approach. And I'm also going to have a look at some exam technique as well. So I've got quite a few example essays that we can go through and mark to see where the strengths are and where people need to work on their exam technique. So I really, really hope that was useful. Thank you very much, and I will see you in the next session. Diolch.